I think it's important to recognize that you're going to have different pockets of practice in America. I think when you think of Alzheimer's and you think of the importance of Radium-223, I tell my patients that what I want to do for them in the context of their progression is to actually expose them to any life-prolonging agent that we have developed. And if you look at the life-prolonging agents in the metastatic castration-resistant prostate cancer, it's very simple. Oral agent number 1, oral agent number 2, Abi-Enza or Enza-Abi, you know, however you think of those, but 2 oral agents. You got docetaxel, you got cabazitaxel, you have Radium-223, and you have sipuleucel-T. There is no other FDA-approved agent that has led to survival improvement in that context. Now, the recent data using olaparib as a PARP inhibitor for men with metastatic castration-resistant prostate cancer with DNA repair deficiencies clearly demonstrate, which is the data that Dr. Maha Hussein presented last year at ESMO and now is published in the New England Journal of Medicine, clearly demonstrated that using a PARP inhibitor, in that case olaparib, in that patient population compared to those who went on to receive an oral agent, right, in the sequential manner, this, you know, meaning you got an oral agent before you progress and you went on and got randomized, if you will, based upon your DNA repair deficiency to either get, you know, a PARP or an oral sequential agent, then PARP therapy led to not only a radiographic progression-free improvement, but also survival improvement. We also have the data looking at cabazitaxel against oral sequential therapy, which is the data also presented last year at ESMO and now published, clearly demonstrated that sequential oral therapy not only doesn't improve survival, but actually could cause detriment to the vast majority of patients who receive sequential therapy. So I would argue that if someone has seen docetaxel-based chemotherapy, has seen one oral agent, my approach would be to sequence those patients to cabazitaxel type of approach, which is in fact the second-line cytotoxic of choice in North America. Those based upon the TROPIC trial and certainly based upon the Proselica data, looking at different dosing of 20 or 25 milligrams per meter square given every 3 weeks. So I think most of us do recognize that if you have seen docetaxel in the frontline sort of cytotoxic type of treatment for castration-resistant metastatic patients, then the second chemotherapy of choice should be docetaxel. So when you look at that, I think that this patient actually could have gone either way, could have actually seen an oral agent, could have seen Radium-223. I think perhaps let me pick on Radium-223 a bit more if I can. I think there's a misconception in our practices in the United States that believe that if I were to use Radium-223, I may not be able to give cytotoxic chemotherapy after because the potential for bone marrow suppression. I think that's really a myth, in my opinion. If you actually look at the AE profile in the Alzheimer's data, and for that matter, in the expanded access data from the European region and the expanded access data from the US that we published several years ago with Dr. Sauter, Oliver Sauter, you clearly actually see that the incidence of grade 3 and 4 neutropenia and grade 3 and 4 anemia or neutropenia and thrombocytopenia for that anemia is in the 1% when you have never seen chemotherapy, which is chemotherapy naive. But if you have seen, you know, chemotherapy, you know, and then you go on docetaxel, you go on and have an increase around 2 to 3 to 4%. So when you look at that data, you know, I remind you the incidence of grade 3 and 4 neutropenia when you do docetaxel in the SWOG 9916, although a bit obsolete today, and the TAX327 is more than that. So I don't think the decision to use Radium-223 should really be based on the concern that if you give Radium-223 before chemotherapy, you may not be able to get chemotherapy, or if you do, then you're going to have an increased toxicity with regards to marrow suppression, and or vice versa, that if you get chemotherapy before, then you may not be able to get Radium-223 because, you know, the ablation in the marrow that chemotherapy may have left in the front or second line of space. I think that one of the challenges of Alzheimer's, and specifically Radium-223 to some extent, is that it's interesting because it's an alpha emitter. So I have to disclose I never use in my career a beta emitter, right? So not to compare them with an alpha emitter, but alpha emitters are big, thick particles, if you will, that have a short penetrance, right? And work through the microenvironment in the bone marrow. And although the true MOA of Radium-223 has really not been elucidated, it can lead to double-strand DNA breaks, you know. And when you look at that, you know, one of the challenges is not only did improve survival, but faces some of the similar challenges to some extent than CIP-LT face, which is you cannot rely on PSA, you cannot rely on objective progression or an objective findings, if you will, because in the trial, scans were not mandated. So they were done ad hoc on the discretion of the treating provider. And PSA, we only saw about a 15, 16% PSA reduction in the patient population. So really, you're not picking Alzheimer's or Radium-223 with the expectation that you're gonna see a PSA decline or the expectation that you're gonna see a change in the findings of the scans. So it is a problem because we are accustomed to like to see PSA reductions, if you will. We also are traditionally accustomed as providers to actually get an oral therapy or cytotoxic therapy and actually follow you with serial imaging scans. Traditionally, we tend to do scans every 3 to 4 months. You know, my practice, we do it every 12 weeks on chemotherapy, or every 3 cycles, excuse me, on chemotherapy. So when you look at that, I don't know when to scan patients. I tend to scan my patients, you know, every 3 cycles of Radium-223, even if they don't have symptoms, because I want to make sure that they're not progressing in visceral organs. So I tend to actually start therapy, get monthly times 3 scan. I actually don't know what the impact of Radium-223 as an alpha meter in technetium-99 bone scan, and certainly don't know what to expect with lymphadenopathy and so on, especially if it's less than 3 centimeters, which was part of the inclusion criteria of the trial. But I like to scan patients in the middle and at the completion of Radium-223. I know so many of my colleagues in the United States will say, Jorge, no, we can actually just get 6 cycles and then scan the patient at the end of the 6 cycles and not even check their PSA. I don't tend to do that. That's just my own bias and practice. What I think is important for the audience is I don't make decisions on that PSA. PSA changes when you are castration resistant. It's really not a reliable way to manage the patient. Perhaps with the exception that if you elected to start oral therapy with AbbVie or ENSA, you know, I do expect to see a PSA with those agents because they work through sort of what I tell my patients. These agents are AR inhibitors. They block AR signaling pathway where you do it through the adrenal gland in the case of AbbVie, or you do it through the AR signaling directly, the AR receptor through enzalutamide. So because they do work through the factory that makes you PSA, you know, I would like to see and expect PSA reductions. So that's my own personal bias. You know, I think the 3 bigger questions here is if you don't see a PSA reduction on oral therapy, do you stop? And when you do so, the second one is if you see declines, but you see transient increases over time, which is what I call the drifter, you know, then when do you make that decision to say it's time to stop if the patient is asymptomatic, feeling well clinically, and radiographically is not progressing, which is sort of, you know, Cougar 302 and Prevail for that matter. Or what about for those patients who have intractable PSA, basically have 0 PSAs or PSAs absolutely down on oral therapy, but at some time they actually develop progressive disease. And there is a thought that some of these patients, a small percentage of patients, may in fact be develop neuroendocrine or small cell phenotype, mostly neuroendocrine disease or poorly differentiated carcinoma. I think we don't know the answer to that, but I think it's fair to say that however you define your sequence, you have to pay attention to what you're going to use to make the treatment decision to continue, to stop, or to move on to a new treatment. And I think PSA alone should not be used. It's about how do I feel, you know, what my scans tell me, what is my PSA doing, and what are really the goals of that treatment in the way up front, how we selected and why we selected that therapy. So if you were to pick CIPT or Alzheimer's with Radium-223, expecting that you're going to have PSA climb, that's not the right way of thinking. If you're selecting all these agents because of survival improvement, then you have to actually, you know, collectively start thinking as to what else are you paying attention to. Quality of life, patient-reported outcomes, very important for us, symptomatic progression, radiographic progression, serologic progression, and so on. I think that the field has changed so much, you know, that actually genomics are part of what we do. And if you think of it, for instance, you know, and go back to the history of this patient was genomically tested, right, at front. So he had high-risk disease, had a high PSA, had a group 4 disease, and he went and had a germline mutational test. Why? Well, if you look at the NCCN guidelines, we clearly have drastically changed how we think of men with prostate cancer. Outside family history, Lynch syndrome, you know, BRCA1, BRCA2. I mean, my mom, my sister had ovarian cancer. So anything that raises a red flag for you as a clinician, then there may be an element of a, you know, familial syndrome. That is one thing. But most patients who are walking in the office with metastatic disease, and for that matter, patients who actually have also high risk prostate cancer, even if they could be cured, have a significant risk of harboring a germline mutation. And that's why the standard practice for us in the United States is, in fact, to do germline testing.